After completing this learning activity, viewers will be able to describe a policy framework for a comprehensive approach to development of the community health worker field, give an overview of key policy issues facing states, advocate for community health worker leadership in developing policies impacting CHWs and their communities, propose strategies for sustainable financing for the employment of CHWs, describe qualities of training and credentialing policies responsive to unique qualities of the CHW workforce, describe recent changes to the Medicaid Preventive Services regulations as a financing mechanism for CHW services.
Public policy refers to a set of guidelines for action by government at the national, state, and local levels. Policy is also the way that governments define issues or problems where government action is necessary. Public policy is created through legislation, the adoption of administrative regulations, and court decisions. Public policy is carried out primarily through rules and regulations and decisions about the allocation of public funding. Community health workers are concerned with many important areas of public policy, including public health, healthcare, housing, education, and economic opportunity. So it can be very valuable for CHWs to become familiar with federal, state, and local policies in these areas and to follow changes in these policies. However, as a profession or workforce, CHWs are themselves increasingly governed by public policy, especially from the federal and state levels. Federal and state policy has begun to influence not only the funding, which makes it possible for CHWs to be employed in paid positions, but also what CHWs can and can't do and how they do it. In the earliest days of CHW history, government policy did not pay a lot of attention to CHWs, so CHWs didn't have much reason to be involved in policy. But as government officials have come to recognize the value of the results which CHWs can produce, there is pressure to expand paid employment of CHWs in public health and healthcare in particular, and with that expansion have come increasing expectations for CHWs to become a mainstream occupation. But as you know, CHWs are different from other health-related occupations, and unlike most other professions, volunteer CHWs are a significant percent of the workforce. So policies affecting paid workers must not be allowed to hinder the work of volunteers. And lastly, as we will see in a moment, the various kinds of policy affecting CHWs are interconnected with each other, which means that policy work in this field can become complicated. Paid CHW positions historically have been funded mainly through short-term grants and contracts for specific activities, often limited to specific health issues or conditions. This has led to unstable employment for CHWs and has contributed to confusion about the definition of the CHW as an occupation. In recent years, interest has grown in creating regular roles for CHWs in ongoing programs in public health, healthcare, housing, and early childhood education, among others. However, funding decisions are always affected by concerns about controlling the cost of government, and other professions may be concerned about shifting spending within a program, fearing that adding CHWs may lead to the loss of their positions. If CHWs are to be treated like other occupations, then everyone involved should have the same understanding of who CHWs are and what they do. Unfortunately, many key people and organizations, such as funders, potential employers, and government officials, are not even familiar with the term community health worker, and in most states there is not a commonly accepted definition of CHW. Furthermore, even though the definitions described in the companion video on CHW roles and skills are commonly accepted around the country, experts in the CHW field do not always see eye to eye on the basic skill requirements for effective work as a CHW. Making CHWs a part of a program such as Medicaid will require that at least the key decision makers are in agreement about these details. Good quality educational programs for CHWs can be expensive. In the case of other professions, a student is expected to invest in the cost of their own education, with financial aid available where necessary. Since many talented CHWs come from low-income backgrounds, employers or third parties may have to bear part of the financial burden for the education and training of CHWs. Only a few organizations have made a substantial financial commitment to this purpose. If large numbers of CHWs are to receive high-quality training, this may require such a commitment. Hundreds of research studies and program evaluation reports have been published on programs and projects involving CHWs. When asked to support the employment of larger numbers of CHWs, decision makers will still often ask for evidence that CHWs are effective, or that the results CHWs can produce are worth the investment. A growing number of credible studies now show such evidence, but there is still no national strategy for filling in the gaps in that evidence. Research around CHWs is also complicated by the wide range of roles and activities in which CHWs may be engaged, and the complexity of the connections between those activities and the ultimate outcomes or results achieved in terms of the health of community members. Policymakers and other stakeholders in a number of states are seeking to implement policy change to expand employment of community health workers in sustainable paid positions. The purpose of this video is to educate stakeholders about the many complex challenges and opportunities to be addressed in the policy areas we have just described. We will discuss financing options for paid community health worker positions in more detail in a moment, but first let's consider some key points about today's reality. As you are probably aware, a very small amount of health-related spending in the United States is devoted to prevention and population health, which are a major focus of CHW activity. Medicare and Medicaid, the two largest sources of support for health care to underserved populations, were created to help cover the cost of medical care. Community health workers were not considered in the initial design of these programs, and program policies in Medicaid and Medicare are just beginning to recognize potential roles for community health workers. And we are all acutely aware of the need to help control the costs of health care in this country. While we are discovering that community health workers have the potential to help control these costs, proposals to fund community health worker positions as new program activity may be perceived as new spending, unless offsetting cost savings can be shown. Only a few states thus far have adopted official definitions and skill standards for community health workers, but many additional states have embarked on processes to create them. In order to do so, of course, in each of these states, CHWs and other key stakeholders will need to come to agreement on such definitions. Common definitions currently in circulation at the national level, such as the general definition promoted by the American Public Health Association and the core roles and competencies from the National Community Health Advisor Study, referenced in the accompanying video on CHW roles, can be very helpful to the states in starting from a common reference point. One of the major challenges in every state embarking on this process will be the quality or attribute of successful community health workers, often described as community membership or community connectedness, which are essential to the integrity of the community health worker occupational identity. But qualities like these are not commonly addressed in public policy as job qualifications. And finally, there is ongoing discussion in a number of states about the question of credentialing or certification of CHWs as a way of expressing these definitions. We will discuss this question further later in this video. Workforce development policy targeting education and training of community health workers presents significant challenges as well. Historically, most CHW training was provided by employers who focused on the immediate needs of specific positions for short-term projects. This has meant that CHWs often received their education in a piecemeal fashion by moving from one position to another. As a mainstream profession, community health workers must have access to comprehensive, well-designed, and affordable educational opportunities. For many professions, an individual will go through an educational program or even a college degree before seeking employment. This is not the pattern with CHWs. For important reasons, it is often preferable for an employer to hire a person with the right attributes or qualities for community health worker work and make education and training available to them. Since most talented CHWs come from underserved and disadvantaged communities themselves, it is not realistic to expect them to finance their own education, but many employers have not been willing to invest significant resources in CHW education. And finally, since most community health worker employment in the past has been short-term, most employers have not thought about career development for CHWs. While many CHWs may choose to move on from work as a community health worker into other related professions, it can be a disservice to the CHW profession itself to treat it as simply a stepping stone to other professions. Employers and others must consider opportunities to make it possible for committed and talented community health workers to have a career as community health workers. A fourth area of policy with significant challenges is investment in research and documentation around community health worker activities. Most research on CHWs has been funded through projects involving very specific CHW activities, so there is no single complete picture of CHW effectiveness available from the data. As noted in the companion video on CHW roles, community health workers perform a wide variety of activities with community members or patients, which may not be captured in the data collection systems designed for research studies. Furthermore, community health workers working in healthcare have historically maintained records of their activities entirely separate from the patient's medical records. Efforts to integrate this documentation have only begun recently. Organizational policies may need to be modified to incorporate documentation of community health worker activities in medical records. Finally, perhaps our biggest challenge or opportunity of all is the fact that policies in all of these four areas are related to each other, which can complicate the policy development process. Let's talk a little bit about what this means.
How do these four areas of community health worker policy interact? First, let's say that the objective or purpose of the public policy is to expand employment of paid CHWs in public health, healthcare, and related fields, mainly for the benefit of improved health in underserved communities. Another way of saying this is to increase demand for the employment of CHWs among potential employers and payers. Now that we know what we want the policy to do, let's discuss how to get that policy made. There are two things that can make it easier or harder to move policy change forward. They're not part of the content of policy, but rather part of the policy process. First, increasing awareness and understanding of the paid CHW workforce among key stakeholders. We must not underestimate the number of decision makers and others who simply don't know about CHWs. They can't be helpful to the process of change, and they may even oppose it if they don't know what we're talking about. Second, involving CHWs in all important decisions. We can't imagine other professionals like teachers or doctors allowing others to determine the future of their profession, but some decision makers feel free to do that with CHWs. The history of most communities that CHWs come from is a history of disadvantage, disempowerment, and disenfranchisement. Leadership and self-determination by CHWs in decisions about CHWs is in a way modeling a process of transforming the communities that CHWs work with. To recap, the purpose of CHW policy is to expand employment of CHWs. When we create these policies, we want to ensure that we are making stakeholders aware of what the CHW workforce is all about. And we want to include CHWs in all important decisions being made. So what will our CHW policy be about? The four areas of policy, again, are sustainable financing, definitions and skills standards, workforce development, and research and data. So what area of public policy would you start with? It seems that most people hone right in on sustainable financing. For example, how can we get Medicaid or Medicare to pay for CHWs? Let's say that we start there. What's needed to move forward on that? Employers and payers need state and federal authorization. State governments and managed care organizations will want to know exactly who or what they're being asked to pay for. They'll want to know what CHWs do and what their qualifications are. They'll also want to know the evidence suggesting that it's cost-effective to finance these services. They will want assurances that enough qualified workers can be prepared to fill these positions. Will employers support these policies if they don't understand community health workers? Will nurses or social workers oppose them if they see these policies as shifting funding away from their positions? Taking another view, let's say you want to start with workforce development. You'd like to get the state or federal government to fund more training opportunities for CHWs. You may represent community or technical colleges or community-based training providers, or you will need them as allies in going after these policies. Colleges want to know whether there will be jobs out there. They'll also want to know what skills they should be training for. You want employers on your side, and you want CHWs to advocate with you on behalf of training that meets their needs. There are coalitions out there in several states who are starting with credentialing or certification as a way for the state government to officially recognize CHWs as an occupation. Getting support for the definition of a new occupation will certainly require stakeholder awareness and education. Creating meaningful definitions of work for the CHWs and what it takes to do that job will be impossible without CHW leadership and engagement. Whatever group works on these tasks will need research and data on what CHWs actually do in your state and on what other states have come up with. And sooner or later, someone will bring up the point that definitions and standards won't change anything unless employers have a strategy for sustainable financing. Does this mean you have to work on everything all at once? Well, in addition to being even more complicated, it takes a lot of people power to work on all these things at the same time. In some states, coalitions have organized into committees according to these areas of policy. But sometimes one committee will cover 2 of the policy areas, or the coalition will recognize that one area of policy will be the main focus of activity for a time, with the others working more slowly in the background. Now, with the basic understanding that everything is connected to everything else, let's turn to some of the key policy issues that states are grappling with in each of these areas.
Let's talk briefly about some key points to consider in the first 3 areas of policy, beginning with sustainable financing. Before we turn to some of the main options in sustainable financing, let's consider some important factors that influence financing issues for community health workers. First, although the Affordable Care Act contains a number of helpful provisions and policies that can lead to opportunities for community health worker roles, there is no single provision in the Act aimed at providing sustainable funding for CHWs. No silver bullet. Second, the major payers for health care in the United States, including the state and federal governments, have had some difficulty understanding the full range of roles played by CHWs in public health and community development. They are more accustomed to paying for specific clinical services to individual patients. Also, anyone familiar with the financing of public health and healthcare is familiar with the dilemma in which the benefits of some activities in healthcare may go to a person or organization other than the one who paid for those activities. For example, when managed care organizations in Medicaid invest in prevention, the long-term cost savings from better health may benefit a different payer, since there is significant turnover in enrollment in Medicaid managed care plans. Finally, many of us have become accustomed to talking about the CHW model, or a community health worker program, or the financing of CHW services as reimbursement. It may be helpful to consider alternate language to discuss financing, since mainstream employment of CHWs will typically not be treated as a separate program. And community health workers are becoming known as a workforce rather than a model of program design. And finally, the term reimbursement is commonly associated with fee-for-service payment models in healthcare, which are rapidly being replaced with methods like value-based purchasing and new structures such as the medical home, in which providers are not paid or reimbursed for units of service. There are many potential options for the financing of paid community health worker employment, but each has its challenges, and no single option presents a complete picture at this point. The discussion of financing options can quickly become very complex, so the table on the screen right now was created as a tool to help organize your thinking on this topic. This table will be available as a separate handout in the discussion materials provided to accompany this video. The table is organized in 3 columns representing 3 basic pathways to financing. Column A on the left, financing through conventional health care. Column B, financing of population or community-based public health activities by CHWs. And column C on the right, representing the new systems of care and payment structures being created as part of healthcare reform, which combine the financing of patient care and some elements of population health. In each column there are 3 rows. Row 1 gives some examples of promising program models in each of the funding pathways. Row 2 shows some of the specific roles which community health workers can play in these models. And row 3 shows some possible payment mechanisms that can be used for each of these models. Row 4 cuts across all 3 columns and serves as a reminder that in most of these forms and methods of payment, community health workers can be employed in a number of different ways, either directly by the payer, by a provider in the healthcare system through contracts or supplemental payments, through contracting with community-based organizations, or through contracting with community health workers as individual contractors or as CHW-owned cooperatives. We would like to draw particular attention to 2 items in row 3, column A, that is, payment mechanisms available in conventional health care. First, managed care organizations are showing increased interest in the potential benefits from employing or paying for community health workers. And second, what we are calling internal financing. A number of organizations are discovering the potential in terms of improved outcomes and financial returns from cost savings in other areas from employing community health workers, to the extent that they are willing to spend their own money or pay for community health workers within their ongoing core budgets without requiring some form of payment from a third party to cover those positions. There has been very little published about internal financing because it is an internal matter related to ongoing operations of a business, and these organizations have very little incentive to publish their results. To summarize, this table is not a formula, but rather a tool to help organize the thinking of groups considering strategies for long-term sustainable financing of paid community health worker employment. It can be helpful to start discussions of sustainable financing with topics known to be of interest to state and private payers for healthcare. The good news is that in all of these areas there is a growing body of evidence of benefit from involving community health workers, including both improved outcomes and cost savings. There have been dramatic results from focusing community health worker-driven care coordination activities on those members or customers using the most healthcare services, including frequent use of emergency rooms. Community health workers have been playing significant roles in the management of chronic conditions for many years, including both direct support and coaching for patient self-management, and more advanced roles such as serving as master trainers in the Stanford Chronic Disease Management Model. In addition to the tragedy of infant mortality, adverse birth outcomes such as premature delivery and low birth weight can lead to costs in the hundreds of thousands of dollars for each birth, and community health workers have proven their ability to reduce the incidence of premature and low birth weight deliveries as well as reducing infant mortality. An ongoing concern in prevention and early detection of cancer has been the low rates of participation in routine screening in low-income communities, especially among people of color, due to historic mistrust of the healthcare system. Community health workers have proven their ability to improve screening rates, leading to more early detection and lower mortality from cancer, and of course reduced cost to payers. Most recently, with attention focused on the problem of hospital readmissions in the Affordable Care Act, both payers and hospitals are interested in reducing preventable readmissions, and there is now published research showing that community health worker-driven follow-up can significantly reduce long-term readmission rates. Naturally, there's a great deal of focus on Medicaid as a source of support for paid community health worker positions, since Medicaid is the largest single source of financing for health care for low-income and underserved individuals. However, Medicaid was designed in 1965 as a program to finance medical care, and has not been treated as a major component of public health until recently. Community health workers are not considered a type of health care provider in federal Medicaid statutes and regulations. However, states, managed care organizations, and providers may pay for the services of community health workers as administrative expenditures, but these expenditures are subject to strict limits. Up to this point, community health worker services financed this way have operated at a very small scale, but this policy limitation may become a factor as interest grows in employing larger numbers of CHWs under Medicaid. Some states have worked around this policy limitation by including community health workers in services provided under waivers, but the so-called 1115 waivers are typically limited to 5 years or less. Most states have turned to managed care for coverage of most of their Medicaid population, and managed care organizations have a great deal of flexibility in the use of their premium revenues, or capitation payments. Medicaid managed care contracts vary widely from state to state, but in most states, managed care organizations can contract with vendors for packages of services which can be provided by a combination of community health workers and other personnel. Patient-centered medical homes have become a major focus of health reform in most states, receiving fixed payments to provide all or most of their patients' care. In some states, such as Vermont, community health workers have become a central focus of the design of medical homes for Medicaid recipients, and this strategy could be pursued in other states. What is the argument for including community health workers in the medical home? The CHW can enable the medical home to establish better communication with their patients, provide frequent follow-up, including home visits, support the management of chronic conditions within the primary care setting, and generally enable the patient-centered care team to consider the complete picture of the lives of patients and their families, thereby enabling the team to deliver better care. You are invited to review the standards for the accreditation of medical homes by the National Committee for Quality Assurance, or NCQA. You will easily observe in many of these standards the potential for community health workers to help the medical home excel on those standards. As one example of a state integrating community health workers into its healthcare reform structure, Oregon has created their own version of accountable care organizations called Coordinated Care Organizations, or CCOs. 16 CCOs were created initially under 2012 legislation and a Medicaid waiver. As part of state statute, CCOs must offer their members access to community health workers and other traditional health workers, which include occupations such as doulas. The state has formed a commission to define scope of practice and skill requirements for these traditional health workers. Importantly, under the Medicaid waiver, the CCOs are allowed to treat the costs of employing community health workers as service expenditures under a special category called flex funding. We will now turn to some of the key considerations in state policy around occupational definitions and standards. Many states are now considering the option of certifying community health workers as a policy tool to create a universal definition and skill standards for the occupation of community health worker within their state. It's important to remember that certification of individuals is only one of several options open to the state. Individuals in other fields, such as diabetes educators and nurses' aides, are certified by a national or state governing body. But it is also possible for a state to choose to certify education and training programs for community health workers, allowing the state to then recognize the documentary proof of completion of such programs, like an educational certificate, as qualification of that individual CHW for employment under state funding. In some states, advocates have promoted the concept of certifying employers as being qualified to receive funding for community health worker positions on the basis of meeting standards for practices such as hiring, training, and supervision. As of this writing, no state has chosen to certify employers of CHWs. The designation of an individual as a certified CHW means the issuing authority has found that the individual possesses the necessary skills to perform the duties of a CHW. This function may be fulfilled by the issuing of a diploma or other form of certificate from an educational program if the state government agrees to accept that certificate as proof of qualifications. Without that acceptance by the state government or some other state or national body, an educational certificate alone does not entitle the individual to call herself or himself a certified CHW. The state itself may issue certifications, as is now the case in Texas and Ohio, and for specific programs in Indiana and Alaska. But it would also be acceptable for a community health worker association or an employer group to issue individual certification if, again, the state accepts that certification as proof of qualifications to be paid through state funding. The question frequently arises as to whether community health workers can or should be licensed as clinical professionals such as physicians and nurses are licensed. This approach is unlikely to be used for community health workers for several reasons. First, licensing makes it illegal for an unlicensed individual to perform the duties of that profession. This would place an unnecessary burden on thousands of volunteer community health workers. But in addition, in 3 states so far, the state's professional licensing bureaus have declined to consider licensing of community health workers in Massachusetts, New York, and Virginia, concluding that there is minimal risk of harm to the public through the practice of community health worker activities by unlicensed individuals. In most states, support among community health workers for individual certification is not universal. There are pros and cons. Supporters of certification say that CHWs deserve respect from other professions. Both CHWs and members of other professions see a benefit in making it clear what community health workers can and can't do. It is also apparent that major funding sources, like the state Medicaid program, will insist on knowing what the qualifications of community health workers are before they will be willing to commit significant funding to CHW positions. And finally, individual certification becomes a personal accomplishment and serves as a credential that the community health worker can take from one employer organization to another. Without it, they must prove all over again to a new employer that they are qualified as a CHW. As many community health workers have said from time to time, they have folders full of certificates from educational workshops. They don't necessarily need a college diploma, but they would like to have something to show for all the work they have put into their own education. On the other hand, opponents of individual certification are concerned that the certification process would screen out individuals who otherwise could be very effective community health workers by imposing formal education or testing requirements which can be difficult for people with limited success in their formal education. They are also concerned with the potential negative aspects of over-professionalizing the community health worker field. One veteran CHW advocate has often said that the medical professions have repeatedly ignored, mistreated, or simply failed to adequately serve low-income and minority communities. So, in his words, why would we want to become like them? Indeed, there are legitimate concerns that standardization and other changes to the community health worker field will somehow crowd out the essential personal commitment and life experience qualifications that have made this workforce so special. Can these negative effects be avoided? Based on discussions in a number of states, it appears possible to design a system for certification of individual community health workers that is responsive to the distinctive qualities and needs of the CHW workforce. The system should provide alternative pathways to pursuing certification, allowing entry for individuals with different learning styles and educational attainment. These pathways should include qualification based on documentation of experience, commonly called grandfathering, which allows individuals to qualify who may have decades of volunteer experience and do not require extensive educational preparation. If specific educational preparation is required as part of certification, that education should be provided in settings that are familiar and accessible to individuals with the appropriate background. Because the educational preparation of CHWs involves core competencies which are primarily interpersonal rather than being based on extensive clinical knowledge, written exams and other conventional forms of learning assessment are not appropriate. There is considerable experience around the country with performance-based assessment through observation, internships, portfolios, and other tools which are more appropriate than exams for many CHW candidates. Formal certification almost always requires continuing education, so there must be a concerted effort to make a range of continuing educational resources accessible to CHWs. And especially in rural states, distance learning options will be important to guarantee access to educational opportunities. But again, those educational programs must be designed in a way that is responsive to the needs and learning styles of this workforce. And finally, as we will say repeatedly, the system must consider and respect volunteer CHWs, and wherever possible, avoid placing unnecessary restrictions on the ability of volunteer community health workers to continue contributing to their communities. Any certification process is going to require that the qualifications for certified community health workers be defined in terms of skill standards. For most states which have completed development of certification or are in the middle of that process, the National Community Health Advisor Study has served as the de facto standard or starting point for consideration of skill requirements. However, since the study was published in 1998, the community health worker field has been evolving with greater emphasis on participation by CHWs in patient care and care coordination. So it is vital for each state to consider the current reality and the future of community health workers in that state in defining both the scope of practice and skill standards for community health worker certification. There will be differences in interpretation between states, but it is vital that CHWs and other stakeholders study and debate the needs of the state and the CHW workforce to assure agreement on the final standards. There is a new effort to re-examine these standards from a national perspective by comparing the interpretations of standards in a number of states. This CHW Common Core, or C3 project, is intended to begin a process of consensus building on common elements of CHW scope of practice and skill requirements across the country. For more information on the C3 project, please send an email to info@c3project.org. For a deeper exploration of community health worker roles and skills, please see the accompanying video entitled Community Health Workers, Understanding Who They Are, What They Do, and the Skills They Need at the web address shown on your screen. We will now talk briefly about policies related to workforce development. We have already introduced some key considerations in workforce development. To review, these are the question of who will pay for the education of community health workers and planning for career development. There are opportunities to leverage resources from state workforce investment boards for community health worker training, particularly in view of the recent approval by the U.S. Employment and Training Administration of CHWs as an apprenticeable trade. The nature of the work of CHWs makes the apprenticeship model attractive to community health workers, employers, and workforce development officials. Mentoring is frequently mentioned as a best practice in community health worker education, and it is integral to the apprenticeship model. Coastal Area Health Education Center in East Texas has secured U.S. Labor Department approval of a design for a one-year apprenticeship for CHWs. Because many community health workers come from the same underserved, low-income neighborhoods they serve, employment of community health workers is also attractive to community development and economic opportunity programs. There are many opportunities for creative partnerships between employers and programs in economic development to subsidize community health worker education. As noted earlier, community health workers who wish to move into other related professions deserve encouragement and support, but it should also be possible for committed and experienced CHWs to make a career while remaining in the CHW field. This requires a commitment to long-term compensation at living wages and also the creation of opportunities for advancement as community health workers, which could include CHW roles as supervisors, trainers, and specialists in particular fields. Lastly, workforce development policy should support the creation of high-quality educational programs for community health workers. What do such programs look like? Experience has shown that quality education for community health workers should include basic core competencies and skills, and not just a focus on the duties of the specific position for which the CHW is hired. Because many CHWs may have had challenges with their earlier education experience, principles of adult learning are particularly appropriate for their education. Experienced practitioners of CHW education and capacity building recommend that teaching be learner-centered and participatory. Cooperative education is preferable to classic competitive classroom models. And the popular education methods created in the 20th century by Brazilian educator Paulo Freire are favored by many for their ability to inspire community empowerment and creative problem-solving skills. Regardless of specific instructional methods, most high-quality CHW education programs emphasize fieldwork and mentoring to complement classroom learning, and they assess progress in learning through practice-based performance assessment. As CHW employment becomes more stabilized and less short-term, employers will need to consider the need and opportunity for advanced training, which should in turn be linked to career advancement. For more information on promising practices in CHW education, see the website www.chw-nec.org for materials from the CHW National Education Collaborative, a 4-year effort focused on college-based programs for community health workers, funded by the U.S. Department of Education. As you can see from the many and varied aspects of policy affecting community health workers, the process of policy change can be complex. We have omitted discussion of policy on research and documentation of community health worker activity for the sake of time, but this area of policy adds further complexity. For a more detailed review of many of the topics in this video and an in-depth exploration of the policy change process, please refer to the 6-part e-learning series available online from the Centers for Disease Control and Prevention entitled Promoting Policy and Systems Change to Expand Employment of Community Health Workers at the web link displayed on your screen. This slide is a summary of some of the important points of strategy to consider in approaching policy change for the employment of community health workers. While it may not be possible to devote equal energy to all 4 of the policy arenas identified earlier in this presentation, it is vital to keep all 4 in mind and to plan for progress in all of them, even if emphasis is being placed on one area at a given time. Experience has also shown that in any state, many employers, other stakeholders, and even community health workers may have limited awareness or understanding of the occupational identity and definition of CHWs, and many employers, payers, and other stakeholders are not familiar with the evidence of the impact of CHWs. We will explore this point briefly on the next slide. In most states, it is relatively easy to identify the key stakeholder groups who will need to be involved, or at least supportive, in policy change efforts. Experience has shown the value of highly visible champions in each stakeholder group who have access to and credibility with others in that group. We have emphasized repeatedly the importance of participation and indeed leadership by community health workers in the policy change process. In most states, this means that networks and associations of CHWs will need support, encouragement, and mentoring to participate effectively. If you do not have state or local CHW networks in your state, then efforts must be made to support organizing of such networks. As is usually the case in policy change, different stakeholders in your state will have different interests related primarily to the use of public funding. Policy initiatives that emphasize reducing preventable use of hospital emergency rooms, for example, may have strong support from payers, but may even be opposed by hospitals themselves at risk of losing revenues. For more information on these and other important principles in pursuing policy change for community health workers, a good resource is the 2009 Policy Statement on CHWs from the American Public Health Association. On the apha.org website, click on the Policy and Advocacy link and look in the policy database for policy number 2009-1. We close this basic discussion of policies with a brief note on building awareness among potential employers of community health workers. Unfortunately, many potential employers in both health and non-health related organizations are simply unaware of the existence of community health workers, or they may have heard of other titles for workers who actually do fit the definition of CHW, but they are not aware of the CHW as a recognized occupation. Still, other employers have heard of CHWs, but have not thought much about them, or they may have recently heard a description of CHWs. But without further exploration of the range of community health worker roles, and particularly for healthcare employers who think primarily of clinical professions, they may have difficulty envisioning how community health workers might fit into their organization. It may be necessary with such employers to explore the major issues and problems they are contending with in order to promote the capacity of community health workers to help them address those problems. There are many employers, however, who appear to be stuck at the well-intended stage, mainly due to the underdeveloped policy infrastructure for sustainable financing of paid CHW positions. So they may see the potential value of community health workers to their organizations, but all too commonly they are waiting for someone to pay them to hire community health workers. The ultimate stage of development for employers from this standpoint is, of course, the true believer, often an organization or individual who have employed community health workers for many years. These employers have embraced the idea of community health workers as an integral part of their organization, and may even have financed community health worker positions out of general revenues rather than dedicated funding streams. Such employers can be very valuable to policy change efforts as spokespersons representing the employer's point of view. This concludes our general discussion of policy as it affects community health workers. We turn now briefly to a specific topic which has generated great interest among CHWs and organizations which support them: a recent change in the Medicaid rules concerning payment for preventive services. Effective January 2014, Medicaid rules no longer require that preventive services be provided by a physician or other licensed practitioner. The sentence in the rules now reads, "recommended by." This seemingly simple change of one word was officially done to make the Medicaid rules in Section 440.130 conform with a related section of the Affordable Care Act. However, even though the change does not specifically mention community health workers, it does open the door to a potentially significant source of ongoing financing of paid community health worker positions. Implementation of this change at the state level is at the discretion of each individual state. In order to take advantage of the opportunity, however, the state must submit a Medicaid state plan amendment, not a waiver, which must specify the following policy choices: which non-licensed occupations are to be authorized for payment, and the qualifications each must have. Note that this does not require the state to implement certification of CHWs. What preventive services will be authorized for payment, which will almost certainly be services that are currently authorized for delivery by licensed clinicians, and which Medicaid recipients or eligibility categories may receive them, such as children, pregnant women, or individuals in long-term care, and what methods of payment will be used, as well as rates of payment. it is unlikely that any state will authorize straight fee-for-service payment for such services, and the most likely mechanism may be a modification to existing Medicaid managed care contracts. It should be noted that this process may take some time, since state officials may be preoccupied with many other complexities in healthcare reform. Some states have opted to postpone a state plan amendment until they have put a more complete community health worker policy infrastructure into place, typically including individual CHW certification. In closing, we would be remiss if we did not hammer home a vital requirement for all policy initiatives related to community health workers. Once again, it is vital that community health workers, both paid and volunteer, be engaged in the policy process in your state. The greater their degree of involvement and leadership in policy development and advocacy, the better, for several reasons. Experience has shown that the policy process can distort the original intention behind the origin of community health workers when other interests become involved. The CHW workforce is unique in its reliance on trusting peer relationships and life experience to achieve valuable outcomes. Other interest groups, even with the best of intentions, may fail to fully understand the heritage of the community health worker and may try to change the definition and skill requirements to make the community health worker look more like other professions. This limited understanding may result in efforts to narrow the CHW's range of activities or scope of practice. It may also lead to adding clinical responsibilities to that scope of practice, which fail to build on the unique strengths of the true nature of the community health worker. These clinical duties may in turn require greater levels of clinical education, which could exclude individuals from certain backgrounds who might otherwise become excellent community health workers. And finally, the word health in the title community health worker may lead many stakeholders to neglect the opportunities for contributions from CHWs in other fields which are not directly healthcare related, such as early childhood education and parenting, family violence prevention, disaster preparedness, housing, and economic opportunity. The perspective of practicing CHWs, particularly those who work in non-healthcare organizations, can be critically important to this awareness. Thank you for watching this video. At the very end of the video, there will be links to obtain a study guide and other useful materials on community health worker policy. We would now like to offer some questions to help you reflect on your learning and on practical aspects of policy change in your own state.